On-the-scene coverage of ACC.14 is supported by Janssen Pharmaceuticals, Incorporated.
I'm Peter Block for On the Scene here at ACC at the annual meeting in Washington, D.C. Reviewing the late-breaking clinical trials, and part of all this is the whole question of transcatheter aortic valve replacement. And there is a study as to whether or not this can be done safely in the cath lab rather than the hybrid OVAR. With me is Vasilis Babalieros from Emory University Hospital. Vasilis, you looked at these data from Emory. Tell me what you looked at and tell me what you found.
Peter, we came up with a very simple question, is whether we can do these cases stripped down in the cath lab with no anesthesiologist, no transesophageal echo, no general anesthesia, and no hybrid OR. And we compared it to our experience that we were previously using all those things in order to do the TAVR.
So the difference is really not necessarily a randomized trial, absolutely not, but a registry sort of the past compared to your new stuff in the cath lab. What'd you find?
Well, it was very interesting findings. First, we looked at our procedural data, our 30-day data, and we even looked out to 1 year to see how these patients compared. At 30 days, the mortality was no difference. In fact, there were zero mortality at 30 days in the patients that were done in the cath lab. If you looked at paravalvular leak rates, they were similar and low, less than 5%. And out at 1 year mortality, there was no differences between the two groups.
So this is not just 5 or 10 patients. Give me the numbers. How many patients did you really look at in the cath lab?
We looked at 140 patients overall, about 70 patients in each arm. We had good follow-up out to about 400 days. Obviously with more follow-up on our older patients that we used to do in the hybrid room, but with good comparison.
So I guess one of the questions that anybody who looks at these data would ask is, didn't you really cherry pick these patients that went to the hybrid OR, and the higher risk ones went there and the lower risk went to the cath lab? How would you respond to that?
So it's a very good question. In May of 2012, when we made the decision to move to the cath lab, we transitioned almost all patients. So within a month or two, 95% of all the patients that were coming in transfemoral were done in the cath lab. Currently, we do 96% of all our transfemoral TAVR in the cath lab. So these were very sick patients. Actually, they looked very similar on the demographic evaluation compared to standard.
So not necessarily sicker patients went to the hybrid OR. You can say that with certainty.
I can definitely say that with certainty. I'll tell you that there probably are some limitations. There are some people that were morbidly obese with severe lung disease that we could not get to lay flat. Those were few and far between. The vast majority can be done awake in the cath lab.
So for the cardiology groups out there that are thinking of starting TAVR, have a good cath lab group, what would you tell them? It can be done easily, should be carefully selected. What would you say?
I think there's a few milestones you have to meet before you go into the cath lab. One, you have to have a lot of experience with TAVR and dealing with patients awake doing high-risk balloon aortic valvuloplasty. You got to be certain where you're going to place the valve, and you have to be perfection at percutaneous access and closure. I think with all of those, you can end up with a big cost savings doing them in the cath lab.
So a little bit of experience, and you can do this in the cath lab and save a lot of money. At least that sounds like a good thing to do. Thank you, Vasilis.
Thank you.